Good evening. I'm Hartford Healthcare's Tina Verona. Well, they're often referred to as the silent killer. We're talking about thoracic aortic aneurysms. Well, now doctors right here at Hartford Hospital are engaged in a study to treat this type of aneurysm minimally invasively. Joining me is Dr. Thomas Divinagracia. He's Chief of Vascular Surgery here at Hartford Hospital. Thank you so much for joining us. This is such an important topic. While it might affect a small group of people, it's vital because these are life-threatening conditions. First, real simple for our viewers watching, what is a thoracic aortic aneurysm?
Well, aortic aneurysms are essentially just bubbles that have formed in the aorta. The thoracic aorta is the part of the aorta that is in the thoracic cavity. The unique thing about thoracic aortic aneurysms is that they can involve the aortic arch, where blood vessels to the brain and the upper extremities also emanate from, and that makes treating those aneurysms in particular a unique challenge.
But thanks to this new study, and Hartford Hospital was selected to participate in this, quite an accomplishment to be selected into this study to do this minimally invasively.
That's
First off, tell us how we were selected to participate in this study.
Well, there was a reasonably rigorous screening process. As we mentioned in the interview, it was both our clinical experience treating thoracic aortic pathology as well as our clinical research capabilities. That the divisions of vascular surgery and cardiac surgery have collaborated very well together over the past several years and beyond. And I think that collaboration, contributed significantly to us being chosen as a site.
So take us through the process in comparison to traditional open heart surgery, which is very invasive, versus now this is minimally invasively. You're going through the groin to get at the aneurysm. Tell us, walk us through the procedure and how it works.
Well, the procedure can be done under even local anesthesia, whereas the treatment of thoracic aneurysms in this part of the body almost always requires general anesthesia and at least a moderate-sized chest incision. The procedure at present for the study device can be done under local anesthesia through the femoral arteries in the groin. The incisions are much smaller, and the recovery time is significantly less.
Mm-hmm. And so tell us in the operating room how this all works. Once you're in the operating room and you're going at this through this minimally invasive device trial that we're participating in.
The patients are laid on supine, and you always have to prep out the groin area so they can get at their femoral arteries. Typically you have to have the left arm or the right arm prepped out as well to go through one of the arm arteries, the brachial arteries, to help deploy the devices. These devices are placed under X-ray or fluoroscopic guidance and always involve some component of angiography, meaning that we place catheters inside the arteries and inject dye to help us localize where we're going to place the devices. But invariably, the patients have had, whether you're using the study device or you're using traditional methods, they've had at least a CAT scan to help plan the procedure.
So you're mapping it out.
Yes, that's correct. Yeah.
Mm-hmm. So we're talking with Dr. Thomas Divinagracia. He's Chief of Vascular Surgery right here at Hartford Hospital about a novel new device approach and a trial that Hartford Hospital physicians are participating in to treat thoracic aortic aneurysms. I want to talk about the importance of this because it's done minimally invasively. You are able to get to a population that would not otherwise be able to be treated for this, maybe elderly or frail patients who could not go through open heart surgery, correct?
That's correct, yeah. This is not traditional open heart surgery even to treat thoracic aneurysms, but as is often the case with newer modalities that are done in a less invasive fashion, you're able to treat older, sicker patients because the procedures are physiologically much less stressful than the traditional, more invasive procedures. But as we've seen with aortic aneurysms in the abdomen, the TAVR procedures for aortic valve replacements, this parallels that there's a whole group of patients that are older and sicker that can receive therapy, definitive therapy, without putting them at high risk because it can be done in a much less invasive way.
Yeah, we invite you to ask Dr. Divinagracia a question about thoracic aortic aneurysms. If you or a loved one has been through this or has it, we definitely encourage you to ask him a question while we have him here for a few minutes. I want to talk about aneurysms itself and how they develop. How do they form?
Well, that's a very good question that's been studied extensively. There's certainly a genetic or familial component. People that have a family history of aneurysm disease certainly should be aware of that and get screened. And abdominal aortic aneurysms and thoracic aneurysms tend to run together in terms of the familial component, as do aneurysms of the femoral arteries and the arteries in the legs. They don't typically relate to aneurysms in the brain in the same way. But in general, patients that are predisposed to this have something about their arterial wall physiology causes their arteries to form bubbles, for lack of a better word, more readily than other people. And you often see these patients have, in general, larger arteries than the general population. But it is key to identify patients that have had these and inform their family members so that they can be screened.
Yeah, and we always talk, whenever we talk about health-related topics, it's always important, no matter what, to really know your family history.
That's true.
So if someone does have a family history of aortic aneurysms, they should be screened, right?
That's correct, yeah.
And what is the screening process like?
Well, in general, it should start with screening for an abdominal aortic aneurysm, which is more common than thoracic aortic aneurysms. And fortunately, that can be done in a very simple fashion through an abdominal ultrasound that is geared to look specifically at the abdominal aorta. And from there, depending on what is found, you often need a CAT scan to look more closely at the thoracic aorta.
And once something is identified, how quickly do you need to act?
It depends on the size that's identified. That's a very good question, but it really depends on the size. In women, around 5 centimeters is the cutoff. 5.5 centimeters is often the cutoff for men. In the thoracic aorta, that increases by about 5 millimeters.
Do you notice that this is something more common in men versus women?
Yes, it is more common in men. Yep.
It is. Do we know why?
There is, I don't know why. I think that's something that's been studied, but there is something, again, about the physiology of the aortic wall that seems to be more common in males than females. But we do see it quite often in females. And interestingly, females that have aneurysms have a higher risk of rupture, even though it's less common.
And so once if you have this, and obviously you don't know if you have it, but do you usually present with symptoms typically, or in some may, you may not?
Yeah, as you mentioned, as it being called the silent killer, these can often grow to extraordinarily large diameters in a completely asymptomatic way. So the asymptomatic component of aneurysmal disease makes it, that's what makes screening critical.
Yeah, no, absolutely. And the screening process is not invasive in any way. It's just
again, it starts with just an ultrasound. Yep.
Yep. So you mentioned the diameter in women and versus men. That's critical. Like if you see something like that, if you see something that's pretty low, do you just monitor the patient at that point? And how does that work?
Depending on the diameter, we have lots of patients that have been identified as having aneurysms, and if they're below the threshold for which we recommend repair, we just monitor them sometimes on a 6-month basis, sometimes on a yearly basis. Abdominal aortic aneurysms can again be just monitored with ultrasound. Thoracic aortic aneurysms have to be monitored using a CAT scan.
And if you do have it, do you have any limitations in your daily life if you do have an aneurysm that you are monitoring? Are there limitations, or can you just lead your normal life?
That is a very good question. I think people often get concerned about doing physical activity when they know that they have these. The two biggest things that we know that increase the risk of growth and potential rupture are smoking and uncontrolled hypertension, high blood pressure. So we really aggressively counsel these people on stopping smoking if they are smokers, and vigorous control of their blood pressure. Otherwise, we tell them that in terms of their activity and everything, they should continue to do what they normally do. It's often the anxiety of knowing it that often limits them to some extent.
Sure. Can smoking facilitate a rupture or a
it does increase the chances of growth, and by increasing the growth increases the chances of rupture and often associated dissection as well.
Well, we have a comment from Kathy Bullens. I hope I'm pronouncing her name right. She says, Dr. D has been my mother's physician for several years now, and he is truly amazing.
Oh, that's right.
Thank you, Kathy, for that. We do have a question from Barbara. She says, my husband had an abdominal aortic aneurysm. At what age should our children be screened?
Very good question, Barbara. Typically, we tell them to start getting screened in their late 40s or certainly by 50 and start off with an abdominal ultrasound geared specifically to look at the abdominal aorta.
And now if nothing is found initially, do you suggest or recommend they come back every year because there is a family history, or how does that work?
Not if the aorta looks completely normal, we typically tell them that they can get checked significantly longer period down the road, often 5 years.
Are there any myths or misconceptions out there about aortic aneurysms that maybe you hear from patients that you'd want to dispel, or is there anything out there that patients should really know when it comes to thoracic aortic aneurysms?
I think one of the big things that we've touched on is the family history and getting screened. The myths often, because people confuse aneurysms in the brain, cerebral artery aneurysms, with the aneurysms that we're talking about, that there's actually no connection there. I think that's one of probably the biggest myths that I hear amongst patients, is that because a family member had a brain aneurysm, that increases their chances of having these types of aneurysms. Thoracic, aortic, and again, like I mentioned, iliac artery and femoral artery, and even what are called popliteal artery aneurysms in the legs are all related in terms of risk, but cerebral artery aneurysms are not.
Let's see, we have a question from Brandon. He says, is the abdominal aneurysm repaired with TEVAR? I'm wondering if he means TAVR like a dissection? TEVAR?
TEVAR. No, that TEVAR is a thoracic aortic. That's the acronym used for thoracic endovascular repair of an aneurysm, which is often confused with TAVR, which is a minimally invasive way of fixing an aortic valve. But EVAR is the acronym we use for fixing abdominal aortic aneurysms.
Got it. So good question, Brandon.
Yes.
So in terms of aneurysms, and we talked about the brain versus very different from vascular, what should really people take away from this discussion?
Again, we're fortunate here at Hartford Hospital to have a robust collaboration, and hopefully that I think the biggest thing is identifying patients that are at higher risk. And whether it's family history, male smoking history, things like that. And their primary care physicians have to be involved in that as well. But identifying the patients that are at highest risks and trying to get them screened appropriately.
And I think also too is that I'm sorry, go ahead.
Right, and then getting, if they screened appropriately, and then in touch with vascular surgeons or whatever practitioners are involved in that region in treating aneurysmal disease.
And I think having this study available here and having us, Hartford Hospital, being able to participate in this study is likely to help so many people that would not otherwise be able to be treated with a thoracic aortic aneurysm.
That is our hope,
Yeah. So thank you so much for taking a few minutes and talking with us
Thank you for
about
having
this. And we thank you for joining us on this evening, this Facebook Live session. If you'd like to learn more information about this procedure and about the clinical trial physicians and surgeons like Dr. Divinagracia is participating in, you can call 1-855-HHC here. I'm Tina Verona for Hartford Healthcare. Thanks for watching. We'll see you next week.